This is the No Stroke Podcast with your co-hosts David Dansero and Michael Garrow, helping you to support and thrive in life after stroke. Their podcast is designed for educational and community support purposes only and should not replace medical treatment and guidance of your own health professional team.
Welcome, everyone, to our last episode, episode 8 of season 2. We're closing out season 2 with a second part to our discussion and kind of coming back, Mike. We are back to where we started, right, in a little ways in terms of the filming here for the recording. Tell us where you are before we introduce our guest today.
I made it over to beautiful rainy Ireland here about, it's my third or fourth day. I think we arrived in last Friday. So over here for a friend's wedding, and then decided to make it down to Kerry, which is in like the southwest pocket of Ireland, not knowing that there was pretty much a hurricane coming through. So we're hunkered down here. Luckily still have power, bit of rain, but enjoying a nice fire. If the fire is still going, yeah, there we go. Sure, see the fire. Little wood, 250-year-old cabin. Not bad to sit down and record a podcast with you today, David.
So super. You know, Mike, this is one that the folks have to kind of jump into the video stream after, because this kicks up your "Where in the World is Michael Garrow" to the next level. And I'm so proud of you for keeping that fire going. But you gotta just promise me that after we finish recording, because we talk about this with our coming on guest here soon, Kate Skeels from Tufts. So this is a take 2 for us. And you've really gone through some extremes to make this happen. So, and including probably jumping on some, you're doing whatever you're doing to get a connection here. So after this, you got to promise me you're going to tune out till you come back to the States, and I'll cross my fingers that hopefully you guys can make it happen. But I want you to enjoy your time. I'm not texting you. I'm not emailing you. This is it. Okay. I'm going to let you know that we got the pod done. And if you can hear it drop over the weekend, that's all I want to hear. Just give me a thumbs up. Okay. Promise right now.
I think I could do that for you.
Okay. All right. So we want to keep it going within the news before we introduce our guest. Do we think we have bandwidth for that right now?
I mean, the guests would be upset, I think, if we didn't continue with our theme, right? So this one you actually pinged over to me, and as I was reading through it, there's a lot of takeaways that then Kate dove into in our discussion. So I think it's a good lead into some of the work that they're doing at Tufts and kind of a lot of the things that have changed in course over the last 18, 24 months. But this was an article actually from the American Stroke Association. And the lead-in title was "Blood Pressure Levels Rose Following Pandemic Shutdown of 2020." Again, that could almost be as obvious as our last in the news article of, what type of fats are good for the vegetable versus meat fats. But I think what was interesting is kind of, some of the areas that they looked at in that article. So do you want to kind of give a quick overview and your takeaways from that?
Yeah, so I looked at it quick and I pushed it over to you, and it actually came up twice. I saw it in the morning on CNN, and then I saw it with local news, top of the hour at noon here. And again, like you mentioned, it kind of follows, like we were half joking about the connection between diet and increased stroke risk, so poor diet increase. But this one, I think they followed some, the data I think came, and correct me if I'm wrong, because I think Cleveland might have been the Cleveland Clinic that was following, and they followed the the increase in blood pressure, and since the start of the pandemic. And I think they were looking at only in women for this particular case, but you can argue that women may have taken the brunt of the shutdown and the stress and everything that came around trying to manage a family. My wife will tell you that we're going to talk about quarterbacking and other things in our episode to come, but she's certainly a quarterback here. And that, what struck me on that article too was, first of all, the high rate, just they did a snapshot of the general population, and I think something like, it's much more than 50% of the population is hypertensive. It might even be something like, or they're borderline. And so the numbers, and we'll get into it in this episode, but the numbers are probably climbing for a number of reasons: the shutdown, the lack of activity, how you're coping with stress, maybe the alcohol consumption. But there's a lot that the group that that we're going to be talking about on this episode, that there's a lot to manage in terms of making sure that individuals, especially now, stay healthy. And blood pressure is just, as that connects back to stroke, is certainly a big risk factor. So my big takeaway was that we're, again, I'm glad it made the news, because certainly managing blood pressure is important. And if it's going the wrong way, we want to know about, how do we intervene? So hopefully, what comes from this is, putting more attention to managing that as a risk factor for overall health, but certainly in stroke. So that's kind of my takeaway on that.
Yeah, that makes sense. And I mean, through that period, everything was so tough, but, we got out of our habits. People weren't commuting, people were adding on, additional stresses to their plate. But I think, it's one, and you and I kind of helped each other a lot out through that period, through the work we were doing with Enable Us, but it was just the accountability of, hey, you shoot me a text, you get out for that walk, you take your couple minutes break here, before you jump into another bit of work. Like, it's important that, I think we're fortunate, but I think for anyone listening, whether you're a survivor or caregiver, it's that accountability, whether it's managing if you're at risk for high blood pressure, hypertension, or really anything that you're looking to accomplish from a goals perspective, that accountability is a huge part of it. And I think that leads in nicely really to what Kate spoke to in her role at Tufts. So I know you had a nice way to kind of frame when we were recording last night. It was right prior to the Bills Patriots game.
Yeah,
I think the game on was, was it a late game for you over there? Or
it was. So it was the feature Monday night game here, and like as we learned from bringing on our guest, she came on and she was getting ready to hunker down with her family for the game, and yeah, so there was a big Patriots Bills game, and we learned Kate Skeels from Tufts, who we're going to introduce here briefly, give you a little background, that we learned in her story is that she has roots in New York. So she's here now in Boston at Tufts, and we're thankful for that. But she definitely was going to be rooting for the Bills, and we here in New England, we're happy at the outcome, but we're not going to. It was a late game, stayed up till the end, but it really, Kate's a phenomenal team member up there at Tufts, and it's going to come across, I think, really clear the minute she comes on and we introduce her. But Kate and I go back to the stroke and young adult program at Tufts. So I had the pleasure of going to some outings with Kate. She's the stroke advanced practice nurse up there at Tufts, and she's been back in Boston since 2009. And it's really great to, as anyone who hasn't listened to season our 7th episode in the 2nd season, the one that precedes this one, the great tie-in with Lester Leung, who you got to meet on the last episode. But Kate will mention and does a much better job of talking about how they became a kind of 2 peas in a pod when they connected through some of their early roles at BI, and then went on to work together at Tufts. And we talked a little bit, setting the stage for the game around the kind of the coaching theme, and Lester set the stage for, in his magic wand question, about what what the when we asked him what the future of stroke recovery looks like, he said that key to the longitudinal model of long-term care for stroke survivorship and best outcomes is to have that sort of 1-2 punch with a nurse practitioner who can take more of a holistic So approach, and really, the interview was great because we were able to see exactly, you asked Kate, like, what's your day like? And like, it's amazing the things she does in one day. But, I mentioned to you before we started recording, I said, that coaching theme and Kate's ending response to her magic question around team. I would say if Lester's maybe the Bill Belichick coach on the sideline, Kate's definitely the quarterback, like executing the plays on the field and day to day, because she had some great themes about like that timeout. We take a timeout, and the playbook and the different things she brings into this interview are just so timely. So I think I have to look at my notes, because if for those listening, if Lester's the Bill Belichick, and Kate for New England fans would be, oh goodness, I'm spacing on the quarterback. Oh, I want to call him the time. Matt Jones. Matt Jones. So, but because Kate is a Bills fan, the head coach there is Sean McDermott, so that would be Lester, and Kate would be had to be Josh Allen. So, I think I try to make that proud, but I think that let's get rolling here, because we go on, and you always have to put the stopwatch on me, so do it for me now so you can get to the rest of your vacation.
Yeah, well, I think you did put it well. And there's always comparisons back to sport, whether it's, in business, in marriage, like, life in general. It's, that connection, that accountability, and, really being able to make that change happen as a unit, right? And Kate really spoke to a lot of how they're doing that within the SIA program, and just some of the great work that's coming through, and only going to advance, here as they continue to grow the program and get more resources in. So yeah, it was a pleasure to kind of, bring Kate in after Lester's discussion. Bill Belichick, we'll give her, I mean, he's still a young fella. He's doing all right this year. Let's just give her the Tom Brady, kudos for now, because I think she deserves it.
Yeah.
Although, as much of a Bills fan, and she probably doesn't want to be, we're Boston strong over here. We're going to keep it going. Tom Brady at heart is a Boston guy. He'll be back. So let's call him the Belichick and Brady duo for the moment, at least. Perfect we've coined it here.
Yep. Perfect way to put it, Mike, because in the end, we're all team, right? And we're all in this together. And we know that, there's a power in team. And so we're going to get this episode started. Just for our listeners, just to know, this is the last episode of this season. I mentioned at the beginning here, I don't want to hear from you for a little bit. We're going to take a little bit of a break transitioning through the holidays into season 3, and we have a great lineup of guests. But great opportunity for our guests to go back and listen to sort of flashback episodes. We've got, we'll have 16 episodes in the archives that are going to be, just as valuable, in the weeks to come as they were at the beginning of the recordings that we did. So, and I think folks can kind of see the progression, and we're building this community. So, so I hope if this is the last time I see you face to face before we record again, I want to just wish you guys all, enjoy your time off. Well deserved, Mike.
Same to you, David, and to our listeners, enjoy the holidays, get some rest. Please do go back. All the episodes kind of have their own unique takeaways. And David and I have been having a lot of fun with it. So I hope it won't be a chore for you to go back. Kind of throw it in as you're setting up the Christmas presents, whatever it is you're doing. And as always, if you find benefit from it, please share with anyone that you think would find these episodes useful. And if you can, please and give us a quick review on either Apple Podcast. And it does help. It does help. So thank you for that. And without further ado, let's bring it into the episode with Kate Skeels from Tufts Medical Center. Thank you.
We are so happy to have Kate Skeels on from Tufts Medical Center. We so happy to make this happen, right? So it was a little bit of a running around last week, and we're actually recording a few days late. But you met Mike briefly, Kate, for a short period of time, but formally here now that we're recording. I wanted to welcome you to the podcast. And Mike, you want to give us a little quick backdrop there for anyone who we are doing video cast as well. So anyone who doesn't again recognize Mike's backdrop.
Yeah, well, thank you, David and Kate. We're super excited to have this discussion with you. Last episode we spoke with Lester, and just teed it up to a brilliant deep dive into the SIA program and your role and what you're doing at Tufts. But yeah, before that, we had a bit of a hiccup with the scheduling last week. I was trying to close things out to get over to Ireland for a nice trip. So anyone who is watching on the YouTube channel will see a beautiful 250-year-old stone wall, at least what they say, a fire. And you know what, guys, I did build that fire. I did.
Very proud of that, aren't you?
We'll see if it lasts the whole episode. But yeah, we make this thing happen, David, and we started it over the Atlantic, and it's the way we're going through this episode. So happy to have you, Kate. And I know, David, we've teed you up in the beginning half of this and kind of give a good overview of your background and obviously the SIA program. But let's take a moment to kind of give the guests a bit of your background and how you've gotten to where you are today.
Yeah, no, thank you both so much for having me here. And yes, you guys set it up brilliantly last episode. Hopefully no pressure with the buildup from Lester either. And it's funny, David, as I was listening to your guys' conversation, I was reflecting, I haven't seen you in person since we were in LA, which is so weird because I don't know, when we were there, I felt like everything was pretty normal. And, I don't know about you, but I recall like riding on the plane home and being like, oh yeah, like people are kind of wearing masks, and like, oh, the participants from China weren't at the conference, like, oh, and then who knew that, a month later things would be shenanigans. So I'm so happy that we can do this over Zoom, and it's amazing, we're from all over the world, or, parts of it right now. And so this is great. So thank you so much for having me and including me. But a little bit about myself. So hi, everyone out there. I am Kate Skeels. I am a nurse practitioner and the stroke advanced practice nurse with the Comprehensive Stroke Center at Tufts Medical Center. And I originally am from actually Western New York, from Rochester. So go Bills tonight. Bills Pats tonight. Big game.
Oh no.
Big Monday night football game. Yeah, well, my daughter is going to be chastised at school today for wearing her Bills dress, I'm sure, but what are you gonna do? So anyways, I grew up in Western New York and went to nursing school at Binghamton University down on the southern tier of New York. And then after college, my now husband and I moved to Boston, and we've been here since about 2009. So the rest is history. And we've been here. And in terms of my nursing, when I started, I worked at Beth Israel Deaconess Medical Center in Boston, and completely honestly fell into neurology by accident. I applied for an RN position on a neurosciences floor and a vascular surgery floor, and interviewed with both. And it just so happened that the neurosciences nurse manager got back to me first. And so that was what I took. And the rest, I've just stayed with neurology ever since, and kind of, fell in love with it. I know that might sound cheesy, but really just learned to enjoy the patient population. And it's actually there where I met baby Lester, where I met Lester. So Lester and his wife, Mia, I think he alluded to, she's a neurologist as well, were residents at Beth Israel when I was a nurse on the neurology floor. And so we kind of, became friends then. We had an amazing camaraderie at that point with our neurology residents and our nursing staff. And we all became really good friends. We were all kind of similar ages, and learned so much from each other and took care of patients together. And then as Lester became a stroke fellow, I actually also moved to the neuro and surgical intensive care unit at Beth Israel. And I was there. And then I completed my master's, my family nurse practitioner degree at UMass Boston. And when I finished, I was looking for a job, and strange place to find a job, but Lester actually posted something on Facebook, the power of social media, but posted something on Facebook being like, hey, all my friends that are nurses out there, is anyone a nurse practitioner and looking for a job? And my nursing friends, that we were all colleagues and knew Lester, like, Kate, you have to apply. Like, Lester's great. He's one of like our favorite neurologists that we ever worked with. Like, don't you remember how great he was as a resident? Like, you should totally apply. And so, yeah, so I reached out to Lester, applied, and we got to talking. And, now those same friends tease, and they're like, oh my God, you are probably the only person that could work with Lester. The two of you are like two peas in a pod and crazy together, but that's what makes it work. So yeah, so that's how I got to be here today.
I didn't know that connection went back that deep. That's great. Thank you for sharing that. When we spoke with Lester on the last episode, he mentioned certainly what makes the Comprehensive Stroke Center unique and compared to other stroke centers. And we definitely got into the enhanced recognition for young adult stroke. I really loved, and we went through with Lester the acronym for Endure, and we've been promoting that ever since. And certainly I'd like to talk to you more about the SIA program, because we did talk about that as well. But Lester, we give everyone on the show a chance to answer their magic wand question at the end, and we're gonna also give you that opportunity. Mike and I often fight who gets to ask that question, but we'll give it to Mike since he looks so relaxed over there. And I know our podcast cannot see Mike in vacation mode. I'm enjoying watching him just chilling out by the fire here as we have this great chat. But Lester, in his magic wand question, really, and I'm gonna kind of, don't want to paraphrase, but he really mentioned the key component to the future of longitudinal care and support was really finding that key that you play. So there's a lot of pressure on you, first of all, as a nurse practitioner, but in that leadership, yeah, I know if anyone knowing, we've got to know each other over the years, if anyone can step up into that role, that is you, for absolutely sure. So, but there's that gap that we talked about. We use the term bridging the gap. I loved it when Lester talked about like moving that rock. There's certain barriers at different phases of care. And we also worked around the theme of coaching. And could you give our listeners sort of a day in the life of your role within the Comprehensive Stroke Center?
Yeah, no, of course, that's a good and loaded question. But yes, I will start off by saying no day is the same. I think it'd be interesting to ask Lester that same question 4 years ago or so and see what he would say. Because I often tease him that he probably got more than he bargained for with me, and I don't know if he actually knew he was looking for me when he got me. I think this role of mine is atypical, which is great. It's unique. It's very multifaceted, and it's evolved and grown since I started. And originally, I was hired because to become a comprehensive stroke center through the Joint Commission, which we are, they ask that you have an advanced practice nurse on your staff, and they don't define really what that needs to be. And so I think that's kind of how Lester and the team that existed at Tufts kind of went into it. Like, we need a nurse practitioner. We want someone who can have a different lens. That lens is a nurse practitioner. And really what it's grown into is a dual leadership between an advanced practice nurse and an MD, which, to kind of answer one of your other questions maybe, is I think what makes part of our center unique is that it has that physician and nurse perspective. And we really try and work together to see it from all angles in terms of clinical care, in terms of, inpatient care, outpatient care, logistics, everyday running of the center. And I think what then has been unique as well is that I, as a nurse practitioner, am also an advanced provider. So there's, various levels of advanced practice nurses. Some of them can practice at an advanced level with patients and write prescriptions. There's also what's called a clinical nurse specialist, who's more focused on education. And then there's other kind of master's prepared nurses that are in leadership and education. But since I'm also a practitioner, part of my requirement for taking the role was that I also wanted to see patients. And maybe by accident, but that has developed into our high-risk stroke clinic, which Lester and I run together, and is also, I think, one of the unique parts of our program too, is that we have this dual provider high-risk clinic that takes care of either medically complex, socially complex, both stroke patients that we think need a little extra TLC, a little extra, support. Kind of, I tell patients sometimes you're getting a 2-for-1 deal. You're getting a vascular neurologist and you're getting a vascular trained nurse practitioner, and we're going to be your team together, and we're going to walk you through this. And at varying, steps, we may or may not, Lester may be more involved or I may be more involved, but all together you get both of us. And so it's funny, the indoor is actually the reason why that came about. I don't know if you shared this, was when I was first starting in clinic, we were trying to frame, how can we, what are the questions we want to be thinking about every time we see a patient in clinic? And so I'm a lover of acronyms. And so Lester came up with this as a way to help me kind of frame my train of thoughts as I was becoming a new stroke provider, in terms of what do I want to think about and look for every time I see a patient. So exactly kind of, he said, I want to know what caused your stroke so I can stop it from another one from happening. But I also, where I think that sometimes gets forgotten, is those competing risk factors. So I want to think about you as a whole, everything about you, what other things not related to this stroke, but what could put you at risk for having a stroke by a different way, and how can we fix that? So maybe you have AFib and your stroke was because of a cardiac embolism, but then you also have hypertension and hyperlipidemia. It would be dangerous to ignore those things. We want to pay attention to those too, so you're not having a stroke by that mechanism. And then, not to go into everything Lester talked about before, but thinking about those complications that can happen. And I think that's the other kind of unique part about our clinic too, both our high-risk clinic and just our longitudinal clinic, is that we see people, every 3 months, then every 6 months, and then every year for as long as they'll see us. I echo Lester. I told a patient the other day, I'm not going anywhere, so you're not getting rid of me. Like, if you want to see me every year, great. If you're like, I'm feeling pretty good, I just want to check in by email with you, that's fine too. Because things will change and things will evolve as you recover. And, maybe initially after your stroke, you're really struggling and you need to see me, like, for example, I had a young patient who worked with commercial vehicles. And so he was really struggling after his stroke because he couldn't drive, because he'd also had a seizure. And so we talked on the phone, I think, weekly for like a month. And then it was like monthly for like 3 months. And now I see him once a year. And, it has a season, where it can be there for you when you need it. And then we can morph and change to what the needs are of people. So now that I'm rambling, that's unique. So I think, lots of unique things.
Yeah. I like the way you put that. It's like, it can be seasonal, right? There can be high risk. There can be times where you need those closer touch points. And now with, with things have changed in terms of, now that things are opening up a little bit more, when things were shut down, certainly there was the pivot in the group, the SIA group that, as I mentioned in the last episode, that I'm proud to be a part of the group there, moved to using virtual meetings. And with that, did you find that, I found them, especially the ones early on, like you mentioned, coming back from LA, didn't realize how extreme things were going to shut down. Like you mentioned, same thing, like there were certain countries that weren't allowed to come in. We were trying to, they kind of eliminated some of the conference attendees, but going back on the plane, not everyone was even wearing a mask at that point, I don't believe. And, flying cross country, coming home, and then within less than a month, we really shut down, completely. So can you talk about like how you guys had to really, pivot, like move in the support group? Maybe did you take on patients via telehealth as well?
Yeah, no, I think it's been a big pivot and a big transition. And, you know, just to kind of like take a step back, as you know, David, and, you know, for everyone else, our support group's a little different than other support groups. It's not a traditional support group in the sense. So stroke and young adults, it's primarily for people who are 55 and younger, or young adults at heart. The idea being just that people within that age group are dealing with different things than maybe someone who's 60, 70, 80. You know, they may be working, they may have kids of their own or trying to take care of their parents. And so kind of different issues socially, and of course, medically, their stroke can affect them differently too. And so we want to honor that uniqueness and what they're going through at that point. Our support group is different in that it's not a traditional support group. We don't usually sit down and kind of talk things out or have an educational component. I think those are fabulous. But what our group does is it's more of a social support group. So our goal when we can go out and about is to get people out. We say, come, bring your families, bring your kids, bring your parents, bring your friends, anyone. You know, Lester and I both usually bring our significant others and our children. I think we brought our dogs one time when we went for a walk. And the idea is to just bring people together. And I usually tell people, you know what, you can talk to people about your stroke, or you can talk about baseball. You can talk about the weather. I don't really care. You can talk about anything you want. The idea is to either get people out of the house, get people up, get people doing things, and to form connections with other people that may be going through something similar. And so that they can form that connection, because as much as me or Lester or, you know, someone, survivor's significant other or family, try and understand what they're going through, on some level, I can't, because I'm not going through it. I'm not a stroke survivor myself. And so that connections that can form inside it can offer that different perspective, that thing that, you know, that perspective that I'm going through it too. So when no one else understands, I can. And so it was a big pivot there, usually we would meet a couple times a year, trying to do 3 or 4 events a year. And we, as David mentioned, I think with mini golf, we try and do some unique things, like we play monster mini golf, get ice cream. We've gone for a walk in the Arboretum, try and do different kind of social events. And so on the computer, obviously it's a little different, but I will say, recognize pretty early that this is a hard time. People are home and people are scared because of what's going on in the world. And so we wanted to be, or try and be, a support, a constant, a familiar support that's out there. And so we tried to have, you know, a few more virtual sessions than we normally would, and try and have a theme and kind of different things we could talk about, whether it's like, what are you excited about for the holidays, or what's your tradition for the holidays? I think that was one of our first ones, and kind of bring people together, you know, in that way. In terms of like clinic wise, the telehealth, I think has been great. I think one of your other speakers, Brooke, mentioned too that, you know, the hybrid model is here to stay. And I think it's a great thing. I think in the periods of time where people couldn't come to the clinic, we relied on telehealth a lot for our clinic visits. We were, you know, doing things over a webcam or a phone. And yes, it's a different neurological exam. A lot of an appointment, though, can be talking anyways and listening to people explain how they're feeling and what their symptoms are. So that part can still work. Where I think it's really nice, though, too, is that for a lot of people, getting to appointments can be really difficult. And so I'd rather be able to see you over a telephone screen or over a telephone receptor than not see you at all. So, you know, those patients who maybe they can't drive anymore because of their stroke and they're a single mom. And so rather than find a daycare for their kid for the day, we can do this, and that's okay. So yeah, I think it's great. I think it's helped a lot of people. And I think going forward, having a combination is going to be best for patients and providers.
Yeah, that's a great answer, and very relevant. I didn't have a chance to you know, to mention this on the last episode, but you know, you mentioned those connections, the distance and everything. Your communication from your team, it was fantastic to be able to, there were individual questions that the communication that went out from your center about when patients were first eligible for vaccinations. And then, you know, on an individual level, everyone probably had follow-up questions that you guys made yourself available. And I did it via telehealth because certainly I have a bit more distance than around the corner in Boston. So I found that just like, it was such a weight lifted just to have a conversation and go, this is what I'm thinking, but I just want to make sure I'm on the right path when, when I had these personal questions around my own house. So thank you guys for that again. And
yeah, of course.
Mike, did because we've been talking around the theme of the power tele, so it's nice to hear that. And does that something? It sounds like you'll continue to use as part of your practice model.
I think so, because like I said, it really, especially at Tufts, we see a lot of patients, from the city, but then we are in the Wellforce network. So we see a lot of patients, for those geographically not from the Boston area. Where Tufts is located in downtown Boston in Chinatown, but we get a lot of patients from North Shore area, as well as from the South Shore and West. So we get patients from all over, short of that. And so transportation into the city can be difficult. And so this allows us to stay in touch with them, and it helps with that model that we have in our clinic of longitudinal clinic and frequency. So wanting to check in. So maybe it looks something like every 3 months, we want to check in, and every other time we're in person, and the other times we're via telehealth, to kind of make it easier so that we can still stay in touch. Or, another example, I have another patient survivor I'm working with right now who's a young man, and he's developed a lot of anxiety after a stroke, and he's trying to get back into working. And what he needs right now is to check in every month. And so a couple of months ago, we actually were checking in every 2 weeks for a 30-minute, chat on the phone, like, hey, how's it going? And not even necessarily, making changes or having a medical appointment, more just like, hey, I'm having a little trouble with this, or this is, I'm working with Mass Rehab Commission, and this is what I need help navigating. And, now we're meeting every month on the phone for a half hour. So being able to do that is something that we couldn't do as easily before. So it's definitely helped.
That makes, yeah. And you know what I'd love to do is kind of dig into this day to day for you, Kate, because it seems like what you do is amazing. Like you're putting out brilliant work, you're helping so many people, but like, it's also the job of trying to like personalize this for everyone, right? You have some people you're meeting with every 2 weeks, some people you're meeting with on an annual basis. Like, how do you manage your day to day as a navigator? That's
a great question. And we totally buried that question in there. No, so I think that also kind of comes back to in the way that my role is unique is that I am a provider, but I also, in the day-to-day running of our stroke center, do a lot of work on process improvement, quality improvement in general for the stroke center and the hospital. Another kind of big component of mine is education, and not just for the patients themselves, but I strongly believe in educating our nursing staff. And so if we can have nurses that are educated and specialized in providing stroke care, then I know that my patients and everybody else's patients on the floor are getting the best possible care they can. So starting at the beginning, boots on the ground, how can I get them as educated and as knowledgeable about stroke as possible? So that's a big part of my role. And then kind of as we've been alluding, another part is those transitions. And so yes, everybody's a little different. There are patients that come to my clinic, but then as part of our comprehensive stroke center work, there are a number of different phone calls. And I think, and the navigator alluded to this too, is, and this is actually a program I would love to build upon with having a dedicated nurse navigator. That will not be my magic wand answer, but that's a wish list thing. Because we right now contact all of our patients that are discharged home within about a week to kind of check in, see how they're doing, make sure they got their medications refilled and whatnot. So to answer your question, a day in my kind of workflow varies a lot, but in general, I would start my morning kind of figuring out who were the stroke codes the day before, kind of what our census is. And then on our neurosciences floor, we have a case management rounds. And so this is a half hour or so kind of sit down where the nurses come with case management, the neurology team, myself. We're often joined by social worker, sometimes the chaplain, PT, OT, kind of those other rehab disciplines, SLP. And we sit down and we go over the patient. So the nurse will present on the patient, and it's an opportunity for everyone to get on the same page. What is the plan for this patient? And part of the system that then Lester and I have developed, we call it a discharge timeout. And so at this point, I take a few minutes to touch base with the neurology resident or PA and team and say, okay, let's time out, stop. Let's think about this patient that's going to be leaving today. What's their diagnosis? And what, is it a ischemic stroke? Is it a TIA? What's going on? What are we calling this? What do we think caused it? As of right now, what is our working thought process? And then based on that, we can touch on a few key elements. So, okay, what's their antithrombotic plan? Whether it be, we're going to start them on a Eliquis or a DOAC in a few weeks because we want to do a repeat head CT to make sure that their, stroke is stable. Okay, what's, their statin medication, kind of key medications. And then we also touch base upon what's their plan for outpatient. So do they need any testing in the next, few weeks before their clinic appointment? And then we figure out that clinic appointment. And so for us, our goal is to have our patients seen after an ischemic stroke within 4 to 6 weeks, and hemorrhages about 6 to 8 weeks in the clinic. And my goal is to have every patient leave the hospital with their appointment date and time. I don't want to leave any opportunity for people to feel like they're going out and they have no idea what's going on for themselves. And so we run that kind of list together and then can go back and kind of build that strategy. What do we need to do to make those points that we just talked about happen, coordinate that? And that's where I think that bridge from the inpatient to outpatient starts. We can get on the same page and we can start to build that plan and then connect that plan with their outpatient provider.
That's brilliant. And for you to kind of take ownership of that at that early stage, I mean, it's key for the patient, right? Because like you said, they could often leave at that moment when they're leaving the hospital. That's probably the second scariest time other than, when they arrived, So are you guys from there? And then, right, so they have that appointment and then you're in touch with them to kind of coordinate this longitudinal, care model that we've been speaking of. On that, like, how do you actually, and I'm sure it's, conversational and you get to see these amazing changes with people happen in the time that you are under their care, but how do you actually like see those results? Is it, something that you're tracking or do you have like biomarkers, like things that you're actually looking at to be like, aha, like, we've achieved another milestone and kind of continuing down that road? Do you use any kind of measurement?
Yeah, so one thing actually that we've implemented in the last year or so is to look at and measure patients' knowledge at their follow-up appointment. And so, we're asking our nurses and we're providing education on certain points. And kind of to the other component of doing this discharge timeout is to come up with the language for the patient's discharge summary and education. And what I mean by that is, we like to use big words in medicine, let's be honest, right? And so if someone's writing in your discharge summary, Miss Skeels, you had a left MCA infarct. Well, WTF does that mean, right? It's so hard for people to know what exactly we're trying to say, even if as a medical provider to another medical provider, we know exactly what they're saying. And so the other kind of part of the timeout is an opportunity for us all to get on the same page so that we can translate, and I can help the team translate that information in the discharge summary to a letter to the patient, a way to define what their diagnosis is. So the letter would look something like, dear Miss Skeels, you were hospitalized with an ischemic stroke. An ischemic stroke is a blockage of a blood vessel that results in a lack of oxygen to a part of your brain. We believe your stroke is caused by a cardiac embolism, which is a blood clot that travels from your heart to your brain. And then we kind of go into, okay, so what are your stroke risk factors? Because I want you to know what's applicable to you. Like, it's important for you to know that PFOs exist, or that high cholesterol leads to it, or the tobacco use is a stroke risk factor. But what's really important is that you know what your risk factors are so that you can make modifications and we can work with you to improve those. So we give them a list of what are your risk factors. And then we also touch base about some of the common secondary prevention or prevention medications that people are on to prevent them from having a stroke, and kind of try and break that down in simple language as well. So an anticoagulant, this helps make your blood thinner and prevents you from having another blood clot. A statin medication helps lower your cholesterol and helps your blood vessels to heal. And so this kind of really just sets people up for knowing what exactly happened, so that when they come to their clinic visit, either with us or, usually they're seeing like their primary care physician first, or they might see other providers, they know what happened. They're not feeling like, I don't know what, I think I had a stroke, I don't know what that means, so they can speak to that. And so what we have developed in the last year or so is a evaluation. So when patients come to their first clinic appointment, we give them a one-page little questionnaire that asks a few simple questions. What is a stroke? What type of stroke did you have? Ischemic or hemorrhagic? What are your stroke risk factors? And what do you do if you develop stroke symptoms? And I thought I was being punny. There's like some BFAST or stroke symptoms, BFAST, RESPECT, and like FIRE or something. But the idea is that we're assessing people's knowledge, and then we actually check that against their discharge summary and say, okay, patient X said they had a hemorrhagic stroke and that their risk factors are they had a cavernoma and high blood pressure. And then we check that against their discharge summary. And sometimes, hopefully most of the time, we find that those are correct things. Sometimes we find a mismatch. And then we can take that information and provide it back to our nursing staff and to ourselves so that we can focus our education and our education initiative on those areas of maybe weakness.
I love that. And, that kind of touches on that point of personalization that I was going to kind of get to next. And kind of the way that you're doing that, it's not overwhelming the patient, right? Because a patient just had a life-changing trauma happen to them. They're now discharged from the hospital. They're, in most cases, with your population that you're building this program for, like you said, the under 55, they might have children at home. There's so many other things that are going through their mind of like, holy shit, how am I going to be dealing with all this, right? So I like that approach, and I can only imagine it's an opportunity to continue to build. And over that year, you're kind of drip feeding that information, because it's easy for either a survivor or a caregiver to come home, Google, and then get a tsunami of information that, one, they don't know where it's coming from. They could be reading horror stories on Reddit or something, who knows? But it's a great way to kind of personalize that care, keep that trust, and that's what I've seen, at least in the conversation, with David and Lester, is it's that personal connection you've been able to build with a stroke survivor, right? And it sounds like the family and the caregivers as well, because that's just as important, for a caregiver to be like, all right, well, this is how my life is changing as well, and how I need to care for my loved one. So yeah, I really, really do like that, and it's needed across the board, right? Because I think that's the number one issue when you see that discharge. And we've spoken to many survivors, and I'm sure obviously you've done outside of the program that you run. It's that confusion. It's that, I've left the hospital and I've felt abandoned. I don't know what step to take next. So, it's a great transition program. And I guess, now that we're in this world of post-COVID and a hybrid model, I think it's a great opportunity for you to be able to leverage that even further and, personalize it a bit more. And like that day-to-day has to be challenging. I guess, kind of how I'll ask this now is, how do you, like, where these articles are coming from? Do you guys build a catalog that you then personalize and send out, or how do you like send the articles or things like that?
Yeah, no, them? I think I know, I promise I'm not avoiding the original question here of what my day's like, but yeah, I think it's a combination. So even pre me starting, Lester had created, and the rest of our team at Tufts had created, a stroke center patient guide, which is kind of a Bible per se, a big old packet of information with everything and not personalized, which also has a point, has a use, because to your point, it's so easy to go on Google and just find all this information. And so on some level, I want to provide you with all that information, but I want it to come from sources that I trust and sources that we trust, so I know that it's accurate. And you might have questions about things that aren't related to you, but are in the stroke world. And so go ahead, read this. And then what we've, developed so far is most recently we have what's called a patient passport. And the idea is that it's a little pamphlet, and hopefully you carry it with you and it passes you along as your journey with us continues. And that is where we can personalize it again and really write a log. I think Lester and I are both big at writing things down for patients. I personally know as a patient, sometimes myself, I need to read it and I need to hear it to be able to process things. And so I also tell my patients when they come to see me in clinic, we're going to talk about the same things, what caused your stroke, every time I see you. And that's okay. Eventually it'll, sink in, because exactly to the point you made, when you're in the hospital, it's like someone turned on a fire hose. There's so much information coming at you. And of course, you're not going to remember it all. How could you possibly? And figure out what of everything we told you, you actually need to remember and apply to, day to day. And so we can kind of chip away at that every time we see you, and really get to what do you need to know today, and what do you need to know going forward, and what kind of can you anticipate might be issues for you, 3 months, 6 months, a year down the road, so that you know about those things as well, so that you're informed.
Yeah, I'll just jump in to add, from the patient perspective, absolutely. You don't go into this having a deep understanding or a big stroke IQ, and there's a lot of lingo to learn. And depending on your condition or whatever the pathophysiology, you're overwhelmed, and a lot do go to Google. So I have to say that being under the care of your group, I'd have to say, I've had some of the most comprehensive after visit summaries that have been sent along to my primary after meeting. And it's wonderful, because it's just, there's a lot to learn and digest during that physical meeting. And then you come away and you're like, okay, I think I'm going to work on this, and this is the next thing that we're going to do medication wise, et cetera. But that it's like, it's so helpful to have that, to share with anyone else who's part of your team. So that's great. And I think Mike brought up a really good point. I think the telehealth model is actually, and I've experienced it with the way I treat my patients now that I'm still doing telehealth, is it does really provide a nice opportunity to continue the educational piece. We know from a little hiccup we had during our conversation that you're very familiar with the clap, right? So that so can you maybe, like Lester alluded to the fact that maybe you were doing some educational, I mean, I've seen your BFast on social. Are there any projects that you're working on the education piece or is it part of just the day-to-day that you put these pieces out there?
Yeah, no, the clap, I got an opportunity to be a video star for a day. So one of kind of going back to the other part of my role, working on education for other providers and for nurses, we require that our nurses annually, and this is part of our Joint Commission certification again, but we require that they have 8 hours per year of stroke-focused education. And so this is another example of where Lester and I are a great team, because I remember one day a couple of years ago having lunch with him, and we were brainstorming, how are we going to educate all these nurses? We could buy modules, we could do this and that. And I said, well, why don't we just host a conference? Like, how hard can that be? Like, right? And he was like, okay. But in true Lester fashion, he humors me and says, okay, Kate, like, that's fine. If you want to do that, we will make that happen. And so this will be our 3rd year. And so again, with having to pivot with the pandemic. So our first year, we hosted our annual Tufts Stroke Symposium. And so we created a single-day conference where we provided continuing education credit for nurses, there were physical therapists, there were social workers, other healthcare providers there. We had speakers from within Tufts, as well as some outside speakers come and be able to educate on various topics. And so we build this curriculum And it was fabulous. And then of course the pandemic happened. And so the last 2 years, we've pivoted and actually had a virtual symposium. Unfortunately, or fortunately, I'm not sure, we don't have it where it's live and virtual, but we were able to still record it and then have that available to our nursing staff. And hopefully, we can continue, if we have to continue down this virtual road, to be able to expand so that we can share the education with other providers at different other hospitals. Because it's a great day, but it's an opportunity again to really expand that knowledge for nursing and for other providers, because going back to what I said before, I want to empower our providers. I want them to be educated. It starts at the bedside. And if everyone can be elevated in their understanding of stroke care and how to take care of patients, then I know that they're getting the best care they possibly can. And so it's super important to us.
I love that. And we were saying earlier that I think I was going to take that last question of building your magic wand, but I'm going to hand this one over to David because I know it means a lot to him here. So take it away, David.
Oh wow! Are we that point already? We could keep going here, but you have to make a prediction on the score after. So I know you got to get your game on here soon. As I know the other half of my family is doing, but not on the Bill side. So, here we go. So, Kate, this is, we're at the point where we're going to hand over the magic wand, and if you had the opportunity to design the perfect stroke rehab or survivor experience, what would that look like? And maybe is that something that that you guys are working towards at Tufts, or how would you see it play out if you had that magic wand?
Yeah. Oh, I love this question. I went back and I'm not gonna lie, I went back and forth a few times in my head prepping for this, like what would I really want? But I think what I've landed on is I would love to build a multidisciplinary stroke clinic. And what I mean by that is I would love to have a clinic with a physician, maybe more than one, but physicians, nurse practitioners, and then other disciplines to help us. So I would love to have a social worker, a physical therapist, an occupational therapist, a speech and language pathologist, all of those teams be able to come together in a clinic. So almost as if you're doing one-stop shopping, so that you can come, and maybe it even looks like something like, you come for your appointment and it's a 3-hour appointment, and you sit down first with the neurologist, and he or she's going to talk to you about the mechanism of your stroke. And then you're going to talk to the nurse practitioner, and we're going to do some education. We're going to go over your medications. Maybe then you meet with the nurse, and they talk to you about smoking cessation, because that's one of your risk factors. And then you can meet with everybody else too in this chunk of time, and it's individualized to you. So I think one of the big ones for me is the social work, which I would find extremely helpful, because I find a lot of times my patients, especially working with young adults, have a lot of questions about returning to work or applying for disability or finances. And I don't know the answers to all of those questions. And so it would be amazing to have someone there to be able to help us with that, so that we can always help you with those questions. I rely on my social worker colleagues a lot right now, but if I had my own social worker in clinic, I think it would just be fabulous. And also to be able to have, the physical therapist, occupational therapist, the speech language pathologist there to, even if you're not coming to them on a weekly basis, if they can be like your lead provider and do an assessment and then help make recommendations to providers in the community, because, ultimately they would be a stroke specialist, and perhaps, where you live, you might be going to physical therapy group that doesn't have stroke trained therapists, which we know exists. But if we could provide some instructions and some additional assistance to those providers, so that we can get everyone the highest level of care and kind of have like a team central neuro clinic, I think that would be my magic wand task. I would love to build that at Tufts someday.
Love that answer. And I love that you ended with team, because I think that's one of the messages that we came away with on the last episode with Lester as well, that that's something that you guys are really working towards and building right now as we speak. And Mike, do you need to put another log on the fire there? Do we need to wrap it up?
I know you've put me in. I think you've given me this role, David, of having to be the timekeeper. But I'll make the hard stuff. But no, it's been a pleasure, Kate. And I love, again, your answer there. Really, what you touched on is that missing key, and oftentimes it's that extra one-to-one support of that. Whether it's a social worker, or a nurse, or a health coach that we've spoken about briefly on this podcast. That's what's missing. And unfortunately, we could go on for another 2 hours about how it's not the reimbursement models or the location, social determinants of health. There's so many factors, but it's people like you, it's people like Brooke and the others that we've been able to speak with on this podcast that are really making the difference. So continue the great work. I hope this magic wand. If I find a leprechaun over here in Ireland or something, I'll give it. I'll be like, hey, any magic you could do here to help Kate. But I love that answer, and you're right. It is that's the key. So continue up the great work. It's been brilliant to speak with you. And again, just as Lester, hopefully we could have you on here as a repeat guest and continue to speak to the great work you guys are doing.
Thank you. I would love that. And it's been such a pleasure and an honor. Thank you so much for having me and including me in this group of providers. It's been great. And yes, David and I we could probably talk all night. So cut us off.
Thank you, Kate.
Thank you. All right. Take care. Enjoy Ireland. Eat Kerrygold. Lots of Kerrygold butter.
It's on the plate for tomorrow's breakfast. So and a little bit of soda bread.
Nice.
But thanks, Kate. Have a nice evening.
All right. Night.
Bye-bye.